want to talk about premature ovarian insufficiency. I'd love you to start off by telling us what does that even mean in terms of, definitions, and what does it mean in real life?
So premature ovarian insufficiency is a condition that results from a decline in the pool of oocytes or eggs in the ovaries. And that's really kind of the main issue. And everything that follows on from it is a consequence of that. So to start with, the group that we're referring to with that definition are women under the age of 40. And what is happening is that you get a fall in the number of eggs. And as a result of that fall, the initial step would be the cycles, ovulation becomes less frequent. So the cycles become less frequent. So oligomenorrhea, which is infrequent cycles, would follow on from that. As a result of that infrequent ovulation, estrogen levels become low. So hypoestrogenism results from that, and that will have the effects of the condition, both from a symptom perspective, but also from a general health, bone, cardiovascular, and cognitive. And that's kind of the combination of it. Now, from a clinical diagnosis and a clinical picture, as a result of this combination, you get a reactive increase in push from the brain with the hormone FSH, follicle-stimulating hormone, which is trying to compensate for that lack of ovulation, the fall. So that's really kind of the triad of diagnosis that manifests from it. And of course, when we say fall and decline in the eggs and oocytes, the other aspect that comes into it is fertility. So if fertility is an issue for that individual, clearly their chances of getting pregnant is likely to become less, depending on how frequent their menstrual cycles are.
And so premature ovarian insufficiency, when does it become insufficiency, and then when does it become failure?
We're really kind of moving away from using the term failure because, as you could imagine, you would look at it and think, it's a word that many people wouldn't sit comfortable with.
Well, it's a very catastrophic word.
So really kind of we're moving away, and the term premature ovarian insufficiency is a term used now. It's interesting when you look at the different terms used. So primary ovarian insufficiency still is used quite a lot. Again, not commonly used. So really the terminology that most people would use now is premature ovarian insufficiency. But it's a good question because it's not a categorical thing. You don't go on from normal ovarian reserve to premature ovarian to menopause overnight. It's a process where you get, of course, if you go back to the physiology, if you go back to human nature and the embryology of the ovaries, eggs are produced during fetal life. And once a female is born, there is no further egg production. In fact, you could say the maximum number of eggs is around 20 weeks fetal age of intrauterine age. And you could say there are about 7 million eggs in total in the ovaries. Then by the time of birth, there are about 2 million. And then there is a gradual reduction without forming any new eggs. So you've got almost like a curve, if you want to look at it and say from birth to menopause. And you could say roughly, give or take, about 2 million at the time of birth. That becomes about 400,000 by the time a woman would have her first menstrual cycle, the menarche. And if you look at it then from menarche to menopause, you've got about 400,000 eggs. You have about 400 ovulation cycles on average till the menopause. So it's a gradual drop. So you could say for each 1,000 eggs in the ovaries, one will ovulate, 999 will kind of disappear, become atretic as described, and that's the process. Now, on average, that goes on from early teens to menopause to average age of 51, with a range of 45 to 55. But some women, that could happen earlier. And so you've got, and of course, that number as well is changing. So we're getting studies to suggest that proportion of women going into premature ovarian insufficiency or early menopause is higher than what we thought it was. So we used to quote about 5% early menopause. That's estimated now to be anything between 8 to 10%, depending on which study you look at and which group of women you're including. Premature ovarian insufficiency, we used to think about 1%. Now it's about some studies suggest up to 3 to 4%.
Wow.
So it's probably higher than what we thought it is. Of course, you have a significant proportion that comes from medically induced iatrogenic, as the term is, premature. So if someone has the ovaries taken out surgically or have chemotherapy, radiotherapy, sort of cancer treatment. So that group, of course, can vary, but the number is probably higher than what we thought it was. So that's kind of the description of it. But going back to the point of saying it is a process where you could say you're going to go from normal reserve to a lower reserve, and that drops. And within that, you're going to get manifestations, and it's not going to be overnight. So you could say as it drops, the cycles may get slightly irregular. As that happens, symptoms may manifest. But that is doing it. It's a drop, but within the drop, there are surges up and down with the hormones, so it can manifest in different ways.
And does this group of women experience different symptoms than people who go through sort of the more average perimenopausal transition or menopausal transition?
If you look at the reported prevalence of symptoms, it's along the same lines. So if you look at hot flushes and night sweats, they're still the commonest symptom. And again, 50-60% is what's been reported. Some studies up to 70-80%, which is these were the figures that you get with natural menopause. So along the same lines, the general symptoms are very similar. Again, you get about 15-20% of women who may not experience symptoms. So again, similar to, let's say, natural menopause, where you could say anything up to a quarter of women may not have symptoms. Of course, the discussion in relation to symptoms will be very different because let's say if you're 50 and you say, my periods have become really infrequent, I think I'm heading into the menopause, do I need to do anything? I would say to you, how are you having symptoms and how are they affecting you? And if you say, I'm fine, I'll say to you, you don't need to do anything. And you have a discussion around lifestyle changes, healthy diet, optimizing weight, etc. But when you talk about premature ovarian insufficiency or early menopause, that discussion would have the health aspect as a prominent aspect of it. Clearly, if the symptoms are an issue, you're going to deal with that separately. But you might say, my periods have changed, but I haven't got symptoms that are bothering me. And we'll still say at that age, you still think for bone, cardiovascular, cognitive will take priority. So you could say there is a role for prevention under 45, which is a different discussion that you would have at 50 or beyond.
So can you just explain to our audience, what are these health concerns? Like, what are the health problems that we see women who have their ovaries removed surgically, or whether they have sort of a primary ovarian insufficiency that's sort of natural? What do they experience long-term that we're trying to prevent?
So estrogen is very protective of the bones. Estrogen is very protective of the cardiovascular system and brain function. And if you look at the incidence of heart disease in women, it's lower than in men. And that's a protective effect of estrogen. So if you look at the incidence of coronary heart events in women under the age of 50, it's lower than in men. And after 50, it gradually increases. And by the time a woman is in her 70s and her 80s, the rate is similar to that in men. And that's all the effect of estrogen. So the effect really is an increased risk of cardiovascular disease. And we've got plenty of observational data that show women who go into premature ovarian insufficiency have a higher risk of cardiovascular disease, cardiovascular mortality, osteoporosis-related fractures, and cognitive impairment and dementia. So these are the effects of estrogen deficiency. What we haven't got, what is lacking, is studies demonstrating the effect of estrogen replacement. So it's common practice. If you diagnose now someone with premature ovarian insufficiency, you will say that we would recommend that you take hormonal replacement. And we've got strong observational evidence to that effect that we would say, even though the studies are lacking, it is standard practice that we would do that, and we'd recommend people will take hormonal replacement until the natural age of the menopause of 50, 51 to protect against that.
Okay. And in terms of this group, do you feel that the group who have like a surgical removal of ovaries, given that they haven't had that gradual change and it's more of a sort of a couple of minutes change really in their status, do they seem to have worse symptoms or different symptoms?
So it's, as you described it, you get that abrupt drop and yes, so everything is going to be more prominent in how it manifests. So yes, symptoms are likely to be more prominent because you've got, all of a sudden you kind of got that drop. And a big part of why you experience the symptoms is the effect of the hormone drop on the brain. And you could say if you have this naturally, it's a process that happens slowly. Of course, when it's happening, surgery is very kind of a very prominent drop. So you could say, of course, the studies show there is more of an effect with surgical menopause because you're getting that, in a way, that rapid drop and sharper drop and more significant drop. Because if you were to have premature ovarian insufficiency and you've got your ovaries starting slowly, but you continue potentially to have intermittent ovarian activity, so you're still producing hormones. So yes, it is more of a concern, really. When you talk about the risks, that's got to be higher, but you're more likely to have worse symptoms in that situation as well.
Obviously, you were talking about how it would seem that we probably have underdiagnosed people, or it's becoming more prevalent. Which one do you think it is, or do you think it's a bit of both?
I would say it's probably a bit of both. I think it's sometimes people going without diagnosis or having changes in cycle pattern and not seeking help. That could be the case. It could be our ways of trying to pick it up. So I would say probably a bit of both. I do think it's difficult because you've got that medically induced menopause, and that, of course, is a very different number depending on where you are. You could be working in an area where a teaching hospital that deals with cancer or a place that deals with cancer, and maybe the prevalence would be much higher within that cohort. Or you could have a population where that isn't the case, and you might have a different. So these studies, I mean, of course, the figure of 1% that has been quoted really goes back to studies from the 80s. And so when you look at the kind of more recent studies, it suggests that the figure is higher, and it's probably a combination of both.
And in terms of cause, like, do we know, again, I'm not talking about people who've had surgical removal of ovaries, but do we know, is there a genetic element, or is there something environmentally that's making this happen?
So whilst there are factors that we know can contribute, genetic being one of them, certain immune conditions could be one of them, and leaving aside, of course, as you said, the medically induced, which could be an aspect, of certain metabolic conditions can be a factor. The vast majority of people we diagnose with premature ovarian insufficiency that's not medically induced are unexplained. So it's a term that people medically describe as idiopathic. And it's basically, at this moment in time, we can't pinpoint it. So if someone was to have natural premature ovarian insufficiency, we do investigations. So you will do chromosomal testing, fragile X mutation. So you look for certain genetic components. You look for potential indications of immune, let's say adrenal immunity or thyroid, not because they cause that, but if you have these, you may also have immunity that may predispose you to have premature ovarian insufficiency. But you could say for the vast majority of people, you don't find a cause, and you would say it's unexplained. And of course, the end point is the same. It's a question of counseling about the effects. It's a question of picking up other issues. It's about counseling other members of the family, where this becomes also more relevant.
On Sunday morning, when I was out walking at Terrigal Beach, which is a local beach, I kept crossing paths with a number of women who all had vests on, just like me, weighted vests. And we all gave each other a bit of a knowing look, because these have become very, very popular in peri and postmenopausal women. You might not know what rucking is, but basically what it is walking with either a weighted vest or a weighted rucksack. I personally opt for the weighted vest because I find it very, very comfortable and very, very quick to put on. So for peri and postmenopausal women, there are definitely a number of health benefits that you can gain from walking with extra weight. One of the health concerns that many women have at this stage of life is developing heart disease. And unfortunately, we know in the postmenopause, the rates of heart disease for women really start to accelerate. So why might rucking or walking with weight change that? Well, basically, whenever you're walking with additional weight, it increases your heart rate more, and it basically makes your heart exercise a little bit harder. So hopefully making your heart a lot more healthy. So that's one of the benefits of rucking in comparison to standard walking. So if you're intrigued and ready to start rucking, my recommendation would be that you start low and go slow. So start by choosing a weight that is 5 to 10% of your body weight at maximum, and take it slowly. Go for maybe a 10 to 20 minute walk at first. Don't decide to go on a 5-hour hike the first time you strap on your weighted vest. So we've been chatting to our friends at Rucksack, and I've got a special discount code for you. So if you go to their website, which is www.rucksack.com, so RUKSAK.com, and use the code Shauna15, so that's SHAUNA 15, you're going to get a 15% discount. So whether you decide to go for a vest or whether you decide to go for one of their backpacks, either way, you're going to get 15% off.
This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.